So in this video we will discuss about tumor lysis syndrome. So what is tumor lysis syndrome? We define tumor lysis syndrome as a clinical syndrome. It is a clinical syndrome that occurs due to rapid breakdown or turnover of rapidly dividing malignant cells. So it is a clinical syndrome that occurs due to rapid breakdown of rapidly dividing malignant cells, as a result of which there is release of nucleic acid, phosphorus and potassium. These intracellular content enter the bloodstream and causes metabolic disturbances. So TLS is considered as a oncological emergency due to its potential and life-threatening complication. So next is when does the TLS occurs? TLS most commonly occur during the initial phase of the treatment. During the initial phase of the treatment, when the tumor burden is very high, especially after the chemotherapy, radiotherapy. What is spontaneous TLS? TLS occurring without initiation of therapy. Without any initiation of the therapy, when the TLS develops, it is called spontaneous TLS. It is usually seen in highly proliferative tumors or the tumor with high turnovers. So now coming to the pathogenesis. So pathogenesis starts with lysis of the tumor cells. So this leads to release of multiple intracellular substances into the circulation like potassium, nucleic acid and the phosphorus. So starting with the potassium. The tumor cell releases large amount of the potassium, the major intracellular cation. This results in hyperkalemia. Hyperkalemia, as we know, is very dangerous because it can cause cardiac arrhythmia and sudden cardiac death also. Now release of large number of nucleic acid leads to formation of lots of purine. The purine ultimately get converted into the uric acid, which causes hyperuricemia. So we can quickly go through the purine metabolism. Hypoxanthine get converted into the uric acid with the help of enzyme xanthine oxidase. First, using xanthine oxidase, hypoxanthine is converted into xanthine, and again using the same enzyme, it get converted into the uric acid. The inhibitor of this enzyme, as we know, is allopurinol. And this uric acid finally get converted into the allantoin with the help of enzyme urate oxidase. This is the enzyme which is not found in human. So ultimately the hypoxanthine or the purine get converted into the uric acid. So a high uric acid level precipitate in the renal tubule, which causes renal vasoconstriction, which causes hyperuricemia, causes renal vasoconstriction. This impairs the autoregulation of the kidney and finally decreases the renal blood flow. So this can lead to acute renal failure. Now coming to the last one, that is hyperphosphatemia. The tumor cell lysis releases lots of phosphorus, leading to the hyperphosphatemia. This excess phosphate bind with calcium. To form calcium phosphate complexes, which leads to finally hypocalcemia. Hypocalcemia may be present with tetany, seizures or cardiac side effects. Coming to the renal injury mechanism, as the hyperphosphatemia and hyperuricemia together promote precipitation of the calcium phosphate stone. Now coming to the diagnostic criteria. So TLS is defined by a laboratory criteria and the clinical criteria. So the name of the criteria is Kerr-Bischoff criteria. It has both laboratory TLS criteria and the clinical TLS criteria. So what our objective is to prevent the clinical TLS, by preventing the lab TLS. Coming to the Kerr-Bischoff criteria for the lab TLS. So it has four component. First is uric acid. The level, if it is more than 8 milligram per dl, value is more than 8 milligram per dl, or increasing 25% from baseline. Second is potassium. If the value of the serum potassium is more than 6 millimole per liter, or increasing 25% from baseline. Third one is phosphorus. The value is different in adult and children. In adult, it is more than 4.5 milligram per dl, and in children it is more than 6.5 milligram per dl, or similarly an increase in 25% from baseline. Any of this can be counted. Now coming to the fourth one, which is hypocalcemia. So there is decrease in calcium level to less than 7 milligram per dl, or more than 25% decrease in baseline of the value of the calcium. So this is the lab TLS criteria. So one thing is to be noted is, when we call lab criteria positive, it is more than 2 value out of 4. It should be more than 2 lab value within 3 days before and 7 days after cytotoxic therapy. Now coming to the clinical criteria. Which is out of these three, which is cardiac arrhythmia, seizure, and the acute kidney injury defined by creatinine more than 1.5 times upper limit of the normal. Now, what are the etiology for development of tumor lysis syndrome? First one is high tumor proliferation rate. Means the turnover of the tumor cell is very high. Second is tumor is very chemosensitive. When the chemotherapy is given, it really melts away. Third one is tumor burden is very high. And fourth one is the pre-treatment uric acid is high, or the phosphate level is high. So pre-treatment hyperuricemia and hyperphosphatemia. Fifth one is pre-existing nephropathy. If there is pre-existing nephropathy, it is a risk factor. And the patient is dehydrated, or the urine is acidic. These are risk factor for development of the tumor lysis syndrome. The question is it only chemotherapy which causes TLS? So answer is no. So apart from the chemotherapy, the radiotherapy, targeted agent like rituximab, or even the steroids can cause tumor lysis syndrome. Now coming to the TLS risk stratification. So the TLS risk stratification is very important because it directly guides the management. Not all patients with malignancy have same risk of developing TLS. Some are low risk, some are intermediate risk, and some are high risk. So why risk stratification is needed? Because it helps to predict the likelihood of the TLS occurring and decide the preventive strategy also. So coming to the first one, which is high risk. So I would suggest you to remember just high risk patient and the low risk patient. In between these two is intermediate risk. So high risk is any acute myeloid leukemia or any acute leukemia, ALL or AML, if the total leukocyte count is more than 1 lakh. AML or ALL if the TLC is more than 1 lakh. First one is this. Second is any Burkitt leukemia. Any Burkitt leukemia is high risk. Any Burkitt lymphoma stage 3 and 4 and LDH more than 2 times upper limit of normal. Any Burkitt lymphoma is stage 3 and 4 with LDH more than 2 times upper limit of normal. So we have discussed 4. Now coming to the fifth one, venetoclax. So CLL treated with venetoclax. Any CLL treated with venetoclax. And the lymph node, size of the lymph node is more than 10 centimeter. Or if the lymph node is more than 5 centimeter and the absolute lymphocyte count is more than 25,000 with elevated baseline uric acid. Now coming to the sixth one, which is adult T-cell leukemia, DLBCL, mantle cell lymphoma with bulky disease with LDH more than 2 times upper limit of the normal. These are non-Hodgkin lymphoma. And the seventh one is lymphoblastic lymphoma. Lymphoblastic lymphoma is stage 3 and 4 with LDH more than 2 times upper limit of normal. And any intermediate risk with renal involvement and the potassium, phosphorus or uric acid is more than upper limit of the normal. So we'll revise once more. So any leukemia, AML or ALL with total leukocyte count more than 1 lakh. First is leukemia more than 1 lakh. Second is Burkitt lymphoma. Okay. Third one is Burkitt lymphoma, not leukemia. Burkitt lymphoma is stage 3 and 4 with LDH more than 2 times upper limit of the normal. Any CLL treated with newer agent like venetoclax and lymph node is more than 10 centimeter. If the lymph node is in CLL, if the lymph node is more than 5 centimeter, then the absolute lymphocyte count is more than 25k with elevated baseline uric acid. Coming to the sixth one, which is adult T-cell leukemia, DLBCL or mantle cell lymphoma with LDH more than 2 times upper limit of the normal. And the last one is lymphoblastic lymphoma stage 3-4 with LDH 2 times upper limit of the normal, or any intermediate disease with renal involvement or the higher potassium, phosphorus and uric acid just more than the upper limit of the normal. So these are high risk. Just remember the high risk category and the low risk. In low risk, we have multiple myeloma, CML, indolent NHL or AML or ALL. WBC count is less than 25,000 and the LDH is less than 2 times upper limit of the normal, or Hodgkin's lymphoma. Revise once more, which is multiple myeloma, CML, indolent NHL, AML, count less than 25,000 and Hodgkin's lymphoma. These are low risk category. So in between these two, we have intermediate risk. We will discuss the treatment plan in the treatment section and the prophylaxis also in the treatment section only. So patients are classified based on the probability of developing TLS. In high risk, the risk of TLS is more than 5%. In intermediate risk of TLS is 1 to 5%. And in low risk, it is less than 1%. The classification helps us to decide who needs aggressive prevention and who can be managed conservatively. Now coming to the clinical feature. The general symptoms include nausea, diarrhea, vomiting, lethargy, which are non-specific, and there may be early warning signs of metabolic derangement. These are non-specific, and these may indicate early warning signs of metabolic derangement. Now, features due to the electrolyte imbalance. For example, first coming to the hyperkalemia. Hyperkalemia can lead to cardiac arrhythmia, and which can present as syncope. This is one of the most immediate life-threatening complication. Second is hypocalcemia. It can present as tetany, carpopedal spasm, tetany. Hypocalcemia can present as tetany, carpopedal spasm, muscle cramps, seizures, or altered sensorium. These are mainly due to the neuromuscular irritability. Now coming to the hyperphosphatemia. This actually combined with calcium to form calcium phosphate, which gets deposited into the tissue. The common sites of deposition are heart and kidney. This can lead to arrhythmia and acute kidney injury. Discussed these things. Now, what are other clinical manifestation? Others are there can be any fluid overload, edema, and congestive cardiac failure. These are often secondary to the fluid shifts and renal impairment and fluid shift. Coming to the prevention. So there are three steps in the prevention. First one is hydration. So hydration is the key. So how much do we have to hydrate? It is 3 liter per meter square body surface area of the fluid intake. Usually we give normal saline or half of normal saline. It actually helps us to wash out the crystals formed in the tubules of the kidney by increasing the renal perfusion. So first of all, we have to hydrate the patient with normal saline or half of normal saline, and the volume is 3 liter per meter square of the body surface area. Second is actually the acidic urine increases the risk of tumor lysis syndrome. Acidic urine increases the risk of tumor lysis syndrome. So, is it there any role of alkalization of the urine? There is no role of routine alkalization of the urine at it. It can promote the calcium phosphate. If you will alkalize the urine, it will promote calcium phosphate deposition in the heart and the kidney. Now, third, coming to the hypouricemic agent. These include allopurinol, rasburicase, and the flavixostat. We will discuss these three individually. First, coming to the allopurinol. The mechanism of action is xanthine oxidase inhibitor. We have already discussed the purine pathway. Purine pathway is hypoxanthine converted into xanthine. Xanthine get converted into uric acid with the help of enzyme xanthine oxidase, and this uric acid get converted into allantoin with the help of enzyme urate oxidase. So, coming to the allopurinol, the mechanism of action is xanthine oxidase inhibition. How much dose we can give? It is 200 to 300 milligram per meter square of the total body surface area. So this comes around 300 mg per oral or IV TDS. Per day. So 100 mg TDS. So what are the indication of the allopurinol? So we can give in prophylaxis and intermediate risk of TLS. We can give allopurinol. In cases of high risk for the TLS, when rasburicase, high risk TLS, when rasburicase not used, or In established TLS, where rasburicase cannot be used. So there are mainly three indications. In intermediate risk, you can give allopurinol. In high risk or established risk, when the rasburicase cannot be used, so you can give allopurinol in this. So what are the disadvantages of the allopurinol? It actually reduces the formation of uric acid. As you can see in this hypoxanthine, xanthine and uric acid. It decreases the formation of the uric acid but does not break down the already formed uric acid. So it does not break down the already formed uric acid. does not break down the already formed. So the onset of action is actually delayed due to this. Onset of action is 3 to 4 days because there is already uric acid. There are already lots of uric acid in the blood. And second one is, first one is does not break down already formed uric acid. Second is xanthinuria. It causes xanthinuria. It can get deposited in the kidney. It can cause xanthinuria by inhibiting xanthine oxidase enzyme. By inhibiting xanthine oxidase enzyme, it can cause increased level of xanthine, which can get excreted in the kidney. So xanthinuria. Second is xanthinuria. It is actually insoluble, so it can get deposited in the kidney. Third one is it has lots of drug interaction, especially with 6-mercaptopurine and azathioprine. So it needs drug dose reduction. So the fourth one is it has hypersensitivity reaction is very common. For example, hypersensitivity reaction is very common. Like it is an important drug implicated in pathogenesis of SGS syndrome. To begin with, we have to start allopurinol 2 to 3 days before and continue up to 10 to 15 days. Continue up to 10 to 14 days after chemotherapy. So we have to start 2 to 3 days before chemotherapy and we have to continue 10 to 15 days after the chemotherapy. So how the dose modification in allopurinol is done? According to creatinine clearance, we have to do allopurinol dose reduction. So if the creat clearance is more than 20 ml per minute, the dose is same as 300 mg per day. If it is 10 to 20, then it is 200 mg per day. If it is 3 to 10, then it is 100 mg per day. If it is less than 3, then it is 100 mg per 36 or 48 hours. Now coming to our next drug, which is rasburicase. Rasburicase is recombinant urate oxidase. So already we know hypoxanthine, xanthine, and xanthine say hypoxanthine. From hypoxanthine there is formation of xanthine. Xanthine say uric acid, and from uric acid allantoin. So from uric acid to allantoin conversion, it requires an enzyme called urate oxidase. So rasburicase is recombinant urate oxidase. So it degrades the uric acid rather than preventing the synthesis. It degrades the uric acid in the blood rather than preventing the synthesis. It is drug of choice in established TLS and high risk TLS. It is also safe in renal failure. So approved in intermediate and high risk TLS prophylaxis and in treatment of established TLS. So you can give in established TLS without any doubt. We can give in high risk TLS. You can also give in intermediate risk TLS also. So it is especially preferred in cardiac and renal impairment when the TLS is associated with cardiac and renal impairment. So what about the efficacy? Efficacy significantly reduces the lab TLS. Significantly reduces the lab TLS. Impact on the clinical TLS is unclear in case of raspberry case. In clinical TLS, role of raspberry case is unclear, and efficacy is more in children's. So we can compare the allopurinol and raspberry case in nutshell case. So effect is, first coming to effect is allopurinol inhibit formation. It decreases uric acid level, already formed uric acid level in the blood. It decreases the uric acid level in the blood. It decreases the formation, allopurinol. Onset of action. So onset of action. Onset of action is allopurinol. In case of allopurinol, it is 3 to 4 days. In raspberry case, it is 3 to 4 hours. So relative efficacy. Efficacy in allopurinol is weak, but efficacy is strong in case of raspberry case. Drug interaction. In allopurinol, there is drug interaction, especially with 6-mercaptopurine or azathioprine. But there is no any drug interaction in case of raspberry case. So any dose readjustment required in case of renal insufficiency? Yes, in case of allopurinol, the dose readjustment is required, but in case of raspberry case, no dose readjustment is required. Contraindication, any contraindication? Allopurinol is associated with hypersensitivity reaction, so we have to be cautious in case of hypersensitivity reaction. So raspberry case is contraindicated in G6PD deficiency patient. Formulation is oral. In case of allopurinol, it is oral or IV. In raspberry case, it is only available as IV. Cost is allopurinol is cheap and the raspberry case is very expensive. Now dosing of raspberry case. What is the dose of raspberry case? It is 0.15 mg per kg in case of intermediate risk. And 0.2 mg per kg in case of high risk. This is to be given for 5 to 7 days. So when to start? Usually started along with chemotherapy. However, such prolonged dosing is not ideally required. Practically. Usually what we give is 3 mg single dose. 3 mg single dose would suffice. But if you are giving a single regime, strict monitoring is required. As we already know, what are the adverse effects? G6PD deficiency. It is contraindication in G6PD deficiency as it can cause intravascular hemolysis and other. First one is G6PD deficiency. It can cause intravascular hemolysis. Other one is it can cause anaphylaxis. It can cause myth hemoglobinemia. Now coming to the last drug, which is febuxostat. Febuxostat. So it is also xanthine oxidase inhibitor like allopurinol, but it has lesser drug interaction and it is safe in renal failure. Dose is 80 mg per day. Indication is similar to allopurinol. Now shortly coming to the management. Now coming to the management part. In prophylaxis, so actually in management part, hydration is the key. So we have now 4 categories. First one is low risk for developing TLS. Second is intermediate risk. Third one is high risk. And the fourth one is established TLS. So in case of low risk, only hydration is required with close observation. In intermediate risk, we can give allopurinol is more preferred than rasburicase with hydration. In case of high risk, rasburicase is more preferred, and in case of established TLS, rasburicase is more preferred. And apart from hypouricemic agent, you have to manage the other electrolytes also, like hyperkalemia. You can give calcium gluconate for cardiac stabilization. How we give? This is given as 10% solution, 10 ampules over 10 minutes. Can be repeated after 10 minutes. Repeat after 10 minutes. 10% calcium gluconate, 10 ml ampule over 10 minutes. You can repeat after 10 minutes. You can also give regular insulin 10 to 20 units in 25% or 50%, 50 ml dextrose. It causes redistribution of the potassium inside the cell. You can also give soda bicarb 50 to 100 ml of 7.5% solution over 20 minutes if acidosis is present. You can also give beta 2 agonist like salbutamol or albuterol. You can also prescribe some cation exchange resin. It's like sodium polystyrene sulfate, which is available as K-bind sachet. So after hyperkalemia, we have to manage hyperphosphatemia. So how do we treat? There is we have to do? So we have to do aggressive hydration. It may require oral phosphate binder, which is available as Sevelamer, which is Sevelamer. Dose is 800 to 800 mg per oral TDS phosphate binder. Next one is how to manage hypocalcemia. If symptomatic, to treat with 10% calcium gluconate, 10% calcium gluconate, IV over 10 minutes. IV over 10 minutes. So thing we have to note is before correcting hypocalcemia, we have to treat hyperphosphatemia. We have to treat hyperphosphatemia first. Then we have to correct calcium, because if we will give calcium without correcting hyperphosphatemia, it will again bind with phosphate to form calcium phosphonate and will get deposited in different tissues. So now coming to the last slide, which is indication. What are the indication for dialysis? First one is oliguria or anuria. Second is refractory hyperkalemia. Third one is refractory hyperphosphatemia. Fourth one is refractory fluid overload. Fifth one is symptomatic hypocalcemia. Last is calcium phosphate product more than 70. That's all we need to know in case of tumor lysis syndrome.